Hi, my name is Doug Seidel. I want to thank you very much for spending your time with us today at this Aerodigestive CME event. I'm a pediatric otolaryngologist and just a small member of a big team here that we call the Aerodigestive team. So for those of you who may be asking or wondering what is the aerodigestive medicine, let me share my screen and give you a brief introduction to this field. So the aerodigestive patient is a patient who frequently has complex problems involving the upper central airway, lungs and pulmonary tree, and the gastrointestinal tract. These could be swallowing problems, breathing issues, motility issues, so many other problems. But the key here is that these problems work together and they tend to feed off of one another. So you can't think of them in isolation or you won't treat the whole problem or the whole patient. Aerodigestive patients are often complicated. They require comprehensive evaluation and diagnostics, require multiple disciplines in their care, and often, but not always, require some form of surgical intervention or diagnostics. As you can imagine, the aerodigestive patient frequently ends up at a freestanding academic children's hospital seeing a wide variety of specialists. This isn't always an easy place, however, to be a patient, and we recognize that. Of course, I can't sell ourselves short. We have a ton of available resources. Our focus is on children and adolescents. We have specialists, treatment protocols, cutting-edge research, and often the necessary facilities for patients with aerodigestive problems. That being said, we also have shortcomings. There are many care providers, which can be overwhelming. The system is large, lots of different locations, a huge campus and room for communication breakdown. And overall, this can just feel less cozy and less personalized. The standard care model in this setting is, seeing multiple different providers at separate clinics and getting separate diagnostics performed. A lot of time, this costs money, costs time, and it limits our ability as physicians to communicate with one another and collect data and enroll patients in things like clinical trials. It also puts us at risk for ordering the same study twice, for patients missing appointments, and for having overall patients becoming lost to follow-up. At the end of the day, this is fractured care. When you consider aerodigestive medicine and all of the things that we do in the ENT world that may overlap with what we see in the pulmonary world, and then you bring in the gastroenterologic issues and pediatric surgical issues, and then, of course, genetics, speech-language pathology, and social work, this can be extremely, extremely confusing, not only for the patient, but for providers. So we try and internalize that confusion at the Aerodigestive Center by keeping it all under one roof. We have a combined approach where we make an initial contact with the patient with a single individual. This is one of our administrative associates or advanced practice providers. The advanced practice providers then perform an intake where they gather all the information from the patient, all of the previous studies, and we put that together in a single note that is reviewed by the entire team. We then decide whether or not we need to order additional studies. And then we put those orders in, and that is all coordinated by our administrative associates. And the patient is seen in a single visit by all providers. And we have formed an itinerary for the patient where they can have these studies done pretty much at the same time. The patient then, if needed, goes for what we call a triple endoscopy, where the pulmonologists, gastroenterologists, and otolaryngologists all perform their procedures in a very standard fashion under a single anesthetic. We then give treatment recommendations, again, in a single setting with all providers there, and we give our summary documents to the patient and our direct contact information. If the patients have a problem, they call that single number again, they talk to the people that they know, and then that call can be triaged to the specific subspecialist as needed. Follow-up can then be with a phone call or a focused clinic visit or a combined clinic if needed. The patients, however, maintain established care with referring providers, and we work with referring providers to maintain this. It's very important. So what does this look like for the patient? They're coming into the clinic. We may do an endoscopic evaluation of swallowing. We may review their chest films or their endoscopic swallowing evaluations or the radiologic swallowing evaluations. We may then take them again for that combined visit in the operating room. It may lead to a much larger operation or a surgical intervention for the patient. But the bottom line here is that we're working together as a team for the better of the patient. What does this mean to families? Well, if you just look at time, we're having fewer clinic visit days, we're having fewer general anesthetics, and we like to think that what we're doing is actually reducing unnecessary repeated additional studies. When we looked at this just anecdotally with one patient, we realized that we actually saved the patient 5 hours of just wait time in clinic, 2 hours in addition to that 5 of the in-clinic time, actually seeing providers, 1 hour of general anesthesia time, which for diagnostics, that's a lot of time. And for this patient who lived at a distance, they saved either 12 to 32 hours, depending on whether they were driving or flying, of total time. So this is a very common theme, and we're happy to be on the actual benefit side of this with the Aerodigestive clinic. But the unfortunate thing is the traditional clinic is still the most common thing that we see. Today's webinar, you're going to hear 2 cases, just 2, and these are common things, the themes that we're going to show you today. You're going to hear from 9 physicians and speech language pathologists. You're going to hear from 5 provider coordinators, and you're going to hear many, many opinions. For each case, please feel free to ask questions in the question section. We will field your questions during the Q&A. We want this to be interactive. We want this to be educational, and we want this to be, of course, beneficial to you. So thank you very much for spending your time with us. And I'm going to turn this over to Dr. Boo for the first case.
Good morning. I'm Mimi Boo, pediatric pulmonologist. And so our first case is a 15-month-old female with a history of chronic cough, recurrent lower respiratory tract infections, and acid reflux. She is currently taking famotidine, budesonide, and albuterol only, and she requires antibiotics for her frequent infections. Her parents want to know why she's never well. So where do we start? Each of the specialists on our team will chime in with their differential and workup. And for the audience, as questions arise, please enter your questions in the Q&A rather than the chat. And we'll start with Dr. Morales, the pediatric pulmonologist.
So from a pulmonary standpoint, and again, this differential is not exhaustive, but we think about asthma and wheezy syndromes in this patient, even though she's not responding ostensibly to the medications she was prescribed. Aspiration, anatomic abnormality, immunodeficiency, cystic fibrosis, primary ciliary dyskinesia, infections, especially like non-tuberculous mycobacteria. Evaluation always begins with history and physical. Chest x-ray many times we'll do in a patient like this, swallow study, immune workup, possibly other imaging such as a CT of the chest depending on chest x-ray and further history. And also review of proper medication use, because if you don't use these properly, you're not going to get a response.
Dr. Balakrishnan?
Thanks, Dr. Bruce. So from the otolaryngology airway surgery side, it would be focused largely on structural and anatomic issues to augment what Dr. Morales just discussed. So this would be things like laryngeal masses or cysts, vocal fold mobility issues, laryngeal clefts, tracheoesophageal fistula, airway stenosis, and in deference to Dr. Fink and Dr. Gugig, I would mention as well esophageal anatomic problems. And then we would think about systemic issues again, as Dr. Morales said. So workup would include, of course, a good H&P. In clinic flexible laryngoscopy, we might combine that with an endoscopic swallow evaluation, like a FEES or a SEES, and video fluoroscopic swallow study, which I know April will talk about in a moment as well. Eventually, we'd probably go to the operating room for triple endoscopy and adjunctive testing with that as well.
Thank you. Next, April Johnson with speech language pathology.
So for a patient who presents with this kind of respiratory history, we always want to know if swallow dysfunction and aspiration could be contributing to the respiratory symptoms. So we would first start with a clinical evaluation and then most likely proceed to an instrumental swallow study, which I'll be discussing later. And then we want to know why the patient is aspirating, if they are, and what we can do to help.
Great. And next, Dr. Gugig with GI.
Yes,
sorry, excuse me, Dr. Fink.
Yeah. So we would want to know how the diagnosis was made. Usually acid reflux doesn't come to us already with a pH impedance study done. Did the symptoms change with the famotidine is a helpful history point. Medically, reflux can be caused by esophagitis, gastritis, or duodenitis, eosinophilic esophagitis, viral H. pylori, or celiac disease are common things that we encounter. And structurally, is there already a stricture present? Is there external compression on the esophagus, duodenal atresia in trisomy 21, or H-type TEF. Constipation should not be overlooked, especially in this age group as a contributor, but not a cause. That can be found on history, and EGD can really help get at most of the things I just mentioned. As far as the chronic cough in this patient, I think a pH impedance study might help us link that to reflux.
Great. Next slide. Well, that's an excellent start. Now we're going to hear a few key discussion points pertaining to this case, and then we'll circle back to our final workup and diagnosis, and then discuss the topic live. So for the audience, as questions arise, please enter your questions in the Q&A. Thank you very much.
Hi, my name is Esmeralda Morales. I'm a pediatric pulmonologist with the LPCH Aerodigestive Center. And we've presented a very brief differential diagnosis for our first case. And at this point, we're going to assume that this case is a case of an aspirator. Therefore, I'm going to present on aspiration from the pulmonary perspective. And you can see the pulmonary perspective in this little cartoon with an esophagus who is bullying this poor little trachea into drinking until it aspirates. On a more serious note, I do not have any professional disclosures. On a more personal note, I must disclose that I tend to aspirate, and I aspirate very much on saliva in very inopportune situations that become very embarrassing. And we all aspirate, and we seem to be prone to aspiration. And interestingly enough, there may be some immunoprotective mechanism operating that would justify this anatomic design that we have, where our breathing tube is essentially next to our feeding tube. And you can see it in this nice schematic where the ventilation seems to be crossing where the digestion goes in a human being. This is in opposition, in contrast to cetaceans, so dolphins and whales, who have a blowhole that's connected to a trachea, but these two pathways of ventilation and digestion do not cross. Luckily, we have protective mechanisms so that we don't have aspiration that tends to become pathologic, at least in the majority of humans. However, we know that some human beings suffer from the pathology of aspiration that we're going to talk about today. And there are three ways that we can aspirate. We can aspirate from above, from swallowing dysfunction. We can have reflux with aspiration, and we can aspirate our oral nasal secretions. There are certain signs and symptoms which may suggest aspiration. In our case, our baby had wheezing that was not responsive to asthma medications, also had chronic cough and recurrent pneumonia. Other signs and symptoms that may suggest aspiration include BRU, apnea bradycardia, choking and gagging on feedings, failure to thrive, intermittent fever spikes, and a wet vocal quality after eating or drinking. Aspiration may be associated with certain conditions, including prematurity, anatomic abnormalities, certain syndromes, certain GI conditions, and certain neurodevelopmental conditions. So why do we care about aspiration? There are definitely adverse consequences of pathologic aspiration that I think we all appreciate. Most appreciated seems to be the acute aspiration pneumonias or aspiration pneumonitis, though again, pathologic aspiration has been connected to brief resolved unexplained events in infants, as well as, more importantly, I think, ongoing airway and parenchymal damage, such as bronchiectasis and bronchiolitis obliterans. This is a picture of a rather inelegant investigation in the lungs of a rabbit after aspiration of 20 cc's of a 10th normal hydrochloric acid. The rabbit did not do well. These are areas of hemorrhage and some doughiness in these poor rabbit lungs. For some more data that's more pertinent to pediatrics, we turn to Boston Children's Hospital, who did a study on 188 patients between 2012 to 2015 who had BRU, and 29% of those underwent VFSS. 73% of those who underwent DFSS had evidence of aspiration or penetration on swallow study. And of all the diagnostic tests ordered to evaluate brew, the VFSS had the highest rate of abnormalities. Bronchiectasis, again, is an important sequelae of chronic aspiration, and it's estimated that 2 to 18% of the burden of bronchiectasis may be secondary to aspiration syndromes. In one review, 100 patients ages 6 months to 19 years with chronic aspiration had 66% rate of bronchiectasis, with 51% of these cases of bronchiectasis in children less than 2 years of age. 16 patients in this study had repeat imaging, and what was promising is that 44% had improvement or resolution of the bronchiectasis. Important to the evaluation of a patient with aspiration from a pulmonary perspective is imaging, and many times we also do bronchoscopy with bronchoalveolar lavage as supporting data. Imaging may include chest X-ray, which can show parabronchial thickening, hyperinflation, segmental and subsegmental opacities, though it can miss early changes. High resolution CT scan of the chest may also show bronchial wall thickening and atelectasis, but as well show tree and bud opacities, more early changes, bronchiectasis, and if utilized with contrast, can show anatomic abnormalities, which may be associated with increased aspiration risk, such as a vascular ring. This is a CT scan of a patient that has Mobius syndrome and has chronic aspiration of her saliva. She has diffuse bronchiectasis in her lungs. On bronchoscopy, we utilize this modality to evaluate the anatomy from the nose to the lower airways for any abnormalities. We can also evaluate level of secretions as well as edema. We utilize a study called bronchoalveolar lavage, where we instill saline into the distal airways to sample the cells, microorganisms, and other non-cellular components of the small airways and alveoli. And sometimes we institute something called sleep endoscopy to evaluate for sleep disordered breathing. Some studies that we can look at are cytologic studies, including lipid-lipid macrophages or gastric pepsin in the airway. The lipid-lipid macrophage index is overall much regarded as an antiquated study with a low sensitivity and specificity for diagnosis. So we are less and less using this. What may be promising to look at aspiration-associated reflux disease is gastric pepsin in the airway. Once aspiration is identified, treatment is definitely multidisciplinary and may include addressing any underlying anatomic abnormality, preventing aspiration by utilizing a safe feeding plan, addressing issues of reflux with aspiration, utilization of azithromycin and inhaled steroids as anti-inflammatories, and addressing sialorrhea if indicated. And now I'm going to turn this over to April Johnson, our speech-language pathologist, who will present on modalities to evaluate the swallow. Thank you.
Hi, I'm April Johnson. I'm one of the speech pathologists on the Aerodigestive team. I'm going to talk a little bit about instrumental assessments of swallowing. I have no disclosures. So we start our clinical feeding evaluation by asking parents for a detailed history regarding feeding as an infant, any gaps in normal developmental progression of feeding. We look at feeding behaviors around meal times. We do an oral mech exam, and we observe patients eating and drinking. We also listen to vocal quality pre and post eating and drinking to see if there's any change. And we also want to know if the patient has any dysphonia that would lead us to recommend a laryngoscopy. The limitation of the clinical feeding evaluation is that we cannot identify silent aspiration. We know that young children who aspirate often do so silently. And in order to make sure that we're not missing silent aspiration in a child with respiratory symptoms, we often will recommend an instrumental swallow assessment to look at functional and structural aspects of swallowing. So the first one of those is a video fluoroscopic swallow study. And this is done in conjunction with a feeding therapist who could be a speech pathologist or an occupational therapist, and radiology. And we have the patient sitting in a chair, and we oftentimes will have the caregiver in front of the patient, feeding the patient when it's appropriate. There are some advantages to this kind of swallow study. The biggest one is that this is a dynamic study that visualizes the swallow function during all swallow phases, so the oral, pharyngeal, and upper esophageal phases. We can identify what strategies benefit swallow safety during that study, so the patient can leave with a safe feeding plan, and we can observe anatomy and physiology of the swallow during the swallow. The most obvious disadvantage is that this study includes radiation exposure. So we have to limit our time doing the swallow studies with the fluoro on, and we have to be really considerate of when we want to repeat this kind of study. The study requires the patient to consume barium so we can see the bolus, and that alters the taste and texture of food, which sometimes limits participation. This is what a video fluoroscopic swallow study looks like. As you can see, we can see the oral cavity, the palate, the tongue movement. We can see aspiration into the trachea, and we can visualize the swallow during the swallow. The other type of swallow study is called a fiber optic endoscopic evaluation of swallowing. In this picture, we see a young infant drinking liquid that has been dyed with green dye. We often use that for older kids, not infants as much. This particular patient is very calm. Many of our patients do not look like this when they're undergoing a fees. But oftentimes for infants, we can get infants to calm, and we can look at an entire feeding if they will tolerate it with this kind of swallow study. We can do this swallow study with patients of all ages, from newborns to adults. We can look at breastfeeding, which is an advantage of this kind of study, and we can look at breastfeeding in the patient's typical feeding position. We can also observe the pharyngeal phase of the swallow and the laryngeal structure. We can look at vocal fold mobility, and this type of procedure has no radiation exposure. The disadvantages of the fiber optic endoscopic evaluation is that the scope insertion is uncomfortable, and it requires tolerance, a certain level of tolerance for us to get information regarding the whole feed. We cannot observe the pharyngeal phase during the swallow due to what is called a whiteout, and I will show you that. So this is the laryngeal anatomy. We have the epiglottis at the bottom of the screen, the vocal cords, and then we can see liquid in this picture in the vallecula and in the lateral channels. And we can see that the vocal cords are open immediately prior to the swallow, and this patient is aspirating right before. So we can see this is aspiration, the vocal cords are open, and the patient does not seem to be coughing, so we could consider this silent aspiration. And as you can see, there's a whiteout right after the swallow, right during the swallow, which allows us not to see the swallow when it's happening, but we can also move the scope right over the vocal cords immediately after the swallow to see if there's any liquid in the subglottis. So recommendations for our patient today, who's 15 months old and presents with respiratory symptoms. I would probably recommend a video fluoroscopic swallow study just because her age is a difficult age to tolerate fees. If we wanted to look at the patient's vocal cords, then I would also do a fees during clinic. The benefit of our aerodigestive clinic is that we do a chart review prior to the day of clinic, and we can recommend a swallow study that can be done prior to coming to clinic. So we have that information when the patient arrives, and we can come up with a safe swallow plan if the patient is aspirating. And with that, I'm going to pass it off to Dr. Balakrishnan.
Hello, I'm Karthik Balakrishnan, pediatric otolaryngologist, and today I'm going to be talking with you about major anatomic causes of pediatric dysphagia. Quick disclosure, I do receive royalties from Springer, but they are unrelated to the content of this presentation.
We're going to talk about three major causes of dysphagia today: vocal fold immobility, laryngeal cleft, and tracheoesophageal fistula. So vocal fold immobility may be congenital or acquired, and it may be unilateral or bilateral. Unilateral congenital immobility is often associated with forceps delivery or so-called birth trauma. Bilateral immobility, when it's congenital, is often associated with Chiari malformation, though rarely it can be associated with heritable syndromes that have been described with both autosomal dominant and X-linked inheritance. Acquired vocal fold immobility is commonly associated in children with cardiac surgery, particularly around the aortic arch, but may also be associated with things like thyroid or brainstem surgery, vincristine neuropathy, which often causes bilateral immobility, tracheoesophageal fistula or esophageal atresia repair, or airway reconstruction surgery. When we assess these children, the gold standard is awake flexible nasolaryngoscopy to assess vocal fold motion. More recently, though, laryngeal ultrasound has become more and more of a desirable alternative, particularly during the COVID-19 pandemic, when we have been trying to minimize aerosol-generating endoscopic procedures. Our group is actually a national leader in laryngeal ultrasound to assess vocal fold immobility. The history is, of course, always critical, and when we think about the symptoms that these children have, typically when they have unilateral immobility, voice and swallow symptoms predominate over breathing symptoms, though those breathing symptoms may be positional, particularly in neonates or young infants. Meanwhile, bilateral immobility patients typically have breathing symptoms that predominate over voice and swallow symptoms because they often have a closed glottis that cannot open due to the immobility. When we think about treating these patients, there are trade-offs we have to consider. The three key functions of the larynx are voice, swallow, and breathing, and we have to balance those. So for example, with unilateral vocal fold immobility, you can see these images where we've done an injection laryngoplasty. So on the left side, you can see that the vocal folds look sort of thin or atrophic, whereas on the right side, you can see one of them looks fatter because we've injected it with a temporary filler. That's great for improving voice and swallow temporarily, but of course we want to avoid over-injection that might compromise the airway. Injection laryngoplasty is a great option for temporization while children potentially recover function on their own. We know that the majority of patients who have immobility after cardiac surgery do recover over time. And so this is a great option to buy them time and keep their swallow safe. If the immobility lasts longer than 18 to 24 months, we may do a more permanent procedure such as a laryngeal innervation or arytenoid adduction surgery. You can see on the right lower images, the laryngeal reinnervation technique where we take a branch of the ansa cervicalis nerve and connect it to the recurrent laryngeal nerve to reinnervate the larynx. Please keep in mind that this does not restore movement to the vocal fold, but it does restore bulk and muscle tone. And so you can think of it sort of like having a permanent injection bulking effect. The data for voice improvement are very good, and the data for swallow improvement with this operation are getting stronger over time. With bilateral vocal fold immobility, in contrast, we want to improve the airway while minimizing compromise to the voice and swallow. So really, we want to enlarge that glottic opening. And sometimes we do that with a destructive procedure like a chordotomy or a arytenoidectomy, as you see in the upper right picture towards the left. Or we may do suture lateralization, where we temporarily pull one or both cords out to open the glottic inlet. You can see that in that rightmost upper picture. There are endoscopic procedures we can do for more definitive intervention, including an anterior and posterior cricoid split, which again, our group is a national leader in. That can avoid tracheostomy in perhaps 70% of patients with bilateral immobility, or a posterior graft laryngoplasty, where we insert a small piece of cartilage into the posterior larynx to spread the cords apart. And you can see that in the pictures at the bottom of the screen. And of course, in some cases, we simply bypass the obstruction with a tracheostomy and we wait, though that often commits children to several years of tracheostomy before they can be ready to decannulate. Laryngeal clefts or laryngotracheoesophageal clefts are classified typically with the Benjamin Inglis system. Types 1 and 2 are the more shallow clefts. They are either above or into the cricoid, and those children tend to have some aspiration symptoms, as well as potentially stridor. Type 3 and type 4 are more severe. They go into either the cervical trachea or deeper, and those kids tend to have severe aspiration symptoms and respiratory distress. And in the most extreme clefts, these are rapidly fatal when not repaired early. And you can see on the top right image, a type 3 laryngeal cleft that extends below the vocal folds, and when we palpate deep into that, it goes all the way through the cricoid. We evaluate these most definitively with rigid airway endoscopy and palpation to determine the depth of the cleft. Flexible bronchoscopy is also an option, and it may be very useful as an adjunct. In a recent study that we published, we found that children with persistent or recurrent wheezing had laryngeal cleft 17% of the time, but flexible bronchoscopy only identified about 2/3 of those. So it's not the gold standard. Here's just a visual image of a type 4 laryngeal cleft. And you can see here that there's really no separation between the tracheal lumen and the esophageal lumen at all. Again, we assess these with a combination of instrumental swallow studies, such as FEES or video fluoroscopic swallow study, rigid airway endoscopy and palpation. Flexible bronchoscopy is really most useful, I think, in terms of determining the pulmonary consequences of these clefts through bronchoalveolar lavage and sometimes the airway pepsin testing. We treat these in some cases with endoscopic repair for the shallower clefts, and you can see the image on the right of a type 3 cleft that's been repaired endoscopically. In the deeper clefts, we typically repair open through the neck, sometimes with cardiopulmonary bypass or ECMO support, and those open repairs are often associated with tracheostomy. Finally, just quickly, tracheoesophageal fistula. H-type fistulae are often missed and may be present as a second fistula. These fistulae are often associated with laryngeal cleft. And of course, once the fistula is repaired, tracheomalacia is still a risk. We evaluate these patients with combined airway and GI endoscopy. And esophagram is also, of course, very helpful. You can see on the right side a very nice bronchogram due to esophageal contrast passing into the airway through a fistula. There are some novel surgical management options as well. Endoscopic repair is an option for some specific fistulae. And for large refractory or complex fistulae, slide tracheoplasty may also be an option. And just a quick video to show you what that looks like. We essentially make a beveled cut in the trachea after separating the fistula, and then slide the trachea over itself to move the tracheal portion of the fistula away from the esophageal portion to reduce the risk of recurrence. So our goal is very much to collaborate with you, and our contact information is here. Please feel free to contact us anytime. Thank you so much for your attention.
Thanks everyone for those presentations. I'm Kara Meister, and we are going to wrap up case 1. So to recap, our patient is a 15-month-old female, history of chronic cough, recurrent lower respiratory tract infections, reflux. She takes famotidine, budesonide, and albuterol each day. She's having frequent infections, and her parents want to know why she is never well. So what we did actually in the clinic is she got a pre-clinic workup consisting of a chest x-ray and a video fluoroscopic swallow study. In clinic, she had a history exam and a FEES exam. We then coordinated triple endoscopy in the operating room. We treated her, we evaluated how we did, and then we had long-term disposition. So her pre-clinic testing revealed an x-ray with parabronchial cuffing, consistent with possible chronic microaspiration and lung disease. Her video fluoroscopic swallow study showed a high risk of aspiration with fins and this atypical movement of barium towards the airway. And in this picture, we can see the column of barium, and then as it transitions from the hypopharynx into the esophagus, we see a horizontal line of barium going towards the airway, which is anteriorly here. So jaw, shoulder, right there towards the airway. We then did an in-clinic history where we learned that she really coughs with an open cup, and at age 8 months, she actually needed ECMO for RSV. So in that consideration, we did a FEES exam with otolaryngology and speech pathology, which revealed normal laryngeal motion, 2+ tonsils. Her GI exam, pulmonary exam, and the remainder of her ENT exam was normal. FEES was suspicious for laryngeal cleft. So here is an example. So the camera is in, we're watching the voice box. We can see the milk. We have to infer the exact moment of swallowing, but if we slow this fees down, what we see is some milk coming down the lateral gutter, most of it going towards the esophagus, but a not insignificant amount actually spilling towards the larynx. And you can see it nicely in this shot, pooling in this interarytenoid space, going right into the airway. Here we are in the operating room. She began with a pulmonary bronchoscopy showing mild edema of the mucosa, her BAL results with neutrophils and lipid-laden macrophages. Otolaryngology, here we are probing the larynx, and we can see this type 1 to 2 laryngeal cleft. Her GI endoscopy was normal, as were her esophageal biopsies. So she was eventually treated after her pulmonary health was optimized and her diet was optimized for thickener. After we got her healthy enough to withstand another operation, she had a laryngeal cleft repair. Dr. Balakrishnan already has shown you some pictures, but here is another example. She then went on to feeding therapy to relearn her swallow and wean her thickener. At 3 months post-operatively, she had done well. She continued to do well through 1 year post-operatively with no respiratory illnesses. We were able to wean the thickener by 6 weeks, and she was able to wean from her pulmonary medications by 6 months. From a long-term standpoint, we discharged her back to her primary care physician, and she did quite well after fixing her structural problem and relearning her functional deficit. So with that, that's the end of case 1, and we're happy to answer it up to any questions. Just feel free to put them in the chat. Okay, team, we've made it through case 1. Thank you all for those presentations. I'm going to pull 2 from the Q&A that have already been asked. And of course, if there are additional, please go ahead and send them through the Q&A. So Dr. Schroyer, she mentioned Costello syndrome, which is an HRAS mutation, and particularly those children being at risk for Chiari malformations. So my question for the panelist is, how does your workup and differential change in our population of children with genetic disorders? Let's start with Dr. Fink.
We see a lot of really complex patients in aerodigestive, and I think it really depends on, is this genetic disorder known or not? Sometimes we have patients that have a constellation of symptoms that undoubtedly have an explanation for them, but we can't find it, or we have a variance of unknown significance or a syndrome that's not well understood. If we, it certainly informs what we might be looking for if we have a known genetic syndrome. We you know, if we happen to know that TEF is found, or we have some components of VACTERL, it might even be aerodigestive, that makes the diagnosis that this is VACTERL syndrome.
Great. Yeah, we definitely see a lot of VACTERL patients in our clinic. April, from a speech standpoint, how do your recommendations change in children with genetic disorders or complex neurological or developmental delay?
Yeah, I think that the first thing I would want to know for any child who presents with a genetic syndrome would be, is the syndrome progressive? Does it lead to progressive deterioration of the swallow? That changes our recommendations. It changes how we look at quality of life measures and feeding and swallowing. And it changes how we look at, you know, if a patient has a laryngeal cleft, that may be a type 1, but also has severe swallow dysfunction, incoordination, and hypotonia, that it makes us think about the case differently and whether or not we want to pursue surgical repair of a laryngeal cleft that's minor in the context of broader swallow dysfunction.
Yes, I totally agree. You know, just because there's a cleft doesn't mean it has to be fixed. We have to look at the whole patient as a unit. There's another great question in the chat. Any in utero surgical repair of tracheoesophageal fistula being done at this time? Or are you not able to diagnose it prenatally? Dr. Balakrishnan, why don't you take this one?
Sure. Thank you, Dr. Meister. That's a great question. So tracheoesophageal fistula can often be diagnosed prenatally. Certainly easier to diagnose when it's also associated with an esophageal atresia, but can be diagnosed very often prenatally. In utero surgical repair of tracheoesophageal fistula is not being done currently. However, there are very near analogs, for instance, fetal tracheal occlusion for congenital diaphragmatic hernia. So I suspect that we will be doing those things in the very near future.
Cool. I have a more general question. How much aspiration is too much, right? So everyone coughs, everyone aspirates. Does every child in the pediatrician's office need to be seen by Aerodigestive? Or is some aspiration okay? And when is it not? Dr. Morales?
So that is, I think you could probably pontificate on that question for a long time. And, you know, maybe when we're having happy hours, we can discuss through our Aerodigestive clinic that, but I'm sure we have other things to discuss that actually have an answer. You know, obviously something like a 10th normal HCl instilled directly into an airway is way too much, right? You know the people where it's grossly too much, right? The people that get the recurrent pneumonias that have kind of an obvious history. But you might have somebody who has some wheezing, and you know, maybe they actually are responsive a little bit to asthma medications, but they have this, you know, you get a history and go like, oh wow, you actually do have something that sounds like dysphagia. I guess I'm obligated to do a video fluoroscopic swallow study. And you might see some swallowing dysfunction that's pretty mild. And maybe that person's never had pneumonias. By the time they get into a subspecialty clinic, a lot of their symptoms are gone. So at those times, sometimes we have to just use our clinical judgment. We use imaging sometimes, but again, imaging x-rays can miss a lot of things. You know, grossly, you may see some parabronchial cuffing, and maybe that would make me go, okay, that is too much aspiration, but is that parabronchial cuffing really from aspiration, or is it from an asthmatic thing? Because you can have two processes going on. So sometimes it's not always as straightforward, but I think in terms of referral, at least for a swallow study, I would say at least get a history of somebody who has the signs and symptoms, and they don't have to be, you know, getting 10 pneumonias. You know, having a few episodes of pneumonias and having some recurrent wheezing that really is not responsive to our pulmonary medications given appropriately, and that's always with the asterisk, can prompt you to get the swallow study. And then if that is normal, great. If it's not normal, and there's gradations of it, you know, if it's very severe and there's some other extenuating circumstances, maybe somebody that you're worried about a genetic syndrome on, then that's going to guide your path, right? There's a lot of ways, there are a lot of things that are going to guide your path. And so, you know, I, in terms of referral, sometimes it's just even trying to get a question, the answer to a question. I have a kid who's aspirating, maybe it's early neurodevelopmental and it just goes away. Some of those children we don't need to see in clinic and you can follow along with, or we follow along in pulmonary clinic with. But the kids where it doesn't go away, or where there's just something else that's kind of leading you along a pathway where you're like, this is not within the realm of, you know, maybe just somebody who has a few episodes of wheezing a year that is gonna get better and maybe just needs a little bit of time neurodevelopmentally. That doesn't mean, you know, because you don't get into Aerodigestive clinic doesn't mean you don't use thickener or anything like that. You know, obviously SLPs and OTs can prescribe a good, you know, feeding regimen to support that person as they get better. If somebody's not getting better, then they may need an instrumental evaluation, or if they have other anatomic abnormalities, genetic syndromes, and those type of things. So that's sort of, you know, who I would put into Aerodigestive, but we don't have a great answer for how much aspiration is too much. I aspirate all the time. We all do. I mean, there's good studies going back into the late, so 1990s, basically, that everybody aspirates in sleep. And so, and I tend to aspirate, and it's worse as I'm getting older. So.
Great.
I'd like to chime in on that. So that's actually a really important question, is what is the consequence of aspiration, and how do we define consequential aspiration? And that's actually one of the main targets for the Aerodigestive Society for this year, is to create practice guidelines around that specific question. So Dr. Meister, that's a great question. And so some of the things that we're considering are, what are the respiratory outcomes of aspiration in terms of illnesses, actual pulmonary function, how does it affect the child's activities of daily life, such as running, playing, and then how does it affect their quality of life? And then in terms of, patients with aspiration, where you recommend therapies, whether it be changes to the way their diet is or pulmonary medications, what is the impact of those therapies on the patient? So those questions are going to be investigated, and more answers to come.
Excellent. Yeah, I mean, it's the $1 million questions, right? And it's a balance of over-treatment, over-diagnosis, and then protecting that precious lung health, especially in the early developmental years. So there's another question in the Q&A. Under what circumstances would you repair a laryngeal cleft by endoscopy? I'll let Dr. Balakrishnan take this one, and then Dr. Fink, if you want to tell him when not to do it, I'll direct that for you guys.
Sounds good. Thank you, Dr. Meister. In general, the type 1 and type 2 laryngeal clefts are repairable endoscopically. Those are ones that are either just between the vocal cords above the cricoid or extend partially into the cricoid cartilage. Some type 3 clefts that go into the proximal cervical trachea can be done endoscopically as well. When we repair endoscopically, obviously we're depending on the child having some degree of stability under anesthesia, being able to breathe on their own, because you can't do the repair with the child intubated endoscopically, and having sort of the cardiorespiratory reserve to tolerate that repair. But those are kind of the common ones. One small thing we can mention too is we will sometimes actually inject shallow laryngeal clefts with filler instead of actually sewing them closed. And that can be a good, quick tool for kids who are either too fragile to sustain a big repair, or for kids where we think their swallow will mature and they will compensate for the cleft eventually, and we just want to temporize them. So a couple of considerations.
Great. I'm going to let Dr. Fink off the hook of telling Dr. Balakrishnan when not to operate, but because the next question is such a good one, and one we also is ever changing. So for those of you that are listening, what are the thoughts on empiric treatment of GERD with medication, especially the new concerns surrounding ranitidine, versus referral admission for formal evaluation with pH impedance and manometry? That's a pretty loaded question.
Wow, yeah, you'll have to keep me honest on that. I think that I use medications to try to help me understand if something is caused by GERD quite often in general gastroenterology. I think that if the symptom is kind of a short-term thing like chronic cough, or if I'm wanting to know if heartburn or something that's kind of instantaneous is caused by GERD, that pH impedance is really helpful, because we all reflux up to 40, 50 times a day can be normal. And so when it crosses into gastroesophageal reflux disease is an important question. And I think that linking a reflux event with a symptom is what really helps with that. And so that's how I would decide oftentimes if a pH impedance is indicated. I was going to say, with starting a medication for reflux, it's just important. You're in charge of that medication when you start it. So I think when I find someone who's been on a medication for a long time and the medication was started and there was never any change and we never evaluated whether or not they're benefiting from it, I think I'm proud to say in clinic, I try to stop as many of these medicines as I start. so that people aren't getting treated unnecessarily. And I think with the ranitidine, you might be referring to that it was tainted or something. And I don't tend to use a lot of ranitidine, except maybe in babies for short term, because they become tachyphylactic to it. So if I'm treating eosinophilic esophagitis or something long term, I'm often going to end up on a PPI. I don't think the evidence that discriminates how the long-term effects of H2 blockers versus PPIs seem to be fairly similar at this point, at least last I checked. So that's why I tend to go with PPIs if I think there's a real indication for it. Ranitidine is nice because H2 blockers in general are nice because they tend to have more effect at nighttime. They also tend to have more effect right when you give it. And a PPI might take 3 or 4 days to get up to a therapeutic level. And so it's really not a very good as needed medicine. Manometry is like a whole topic in and of itself. I think manometry is very useful. Not all esophageal disease is structural or even medical. Some of it is motility related. And so that is something that we fold into our aerodigestive evaluation, and our motility center is something that is very much up and coming. We're just kind of putting it together now, but we have hired a new director, so I'm happy to announce that.
Excellent. So that's the perfect question to lead us into our next case, actually. So we're going to do that. If you have further questions related to the first case, aspiration in general, or just questions about aerodigestive, keep them coming in the Q&A.
So our second patient is a case of a 6-year-old boy with eczema and allergies who presents with 3 years of chronic cough, recurrent croup, and intermittent dysphagia. Parents are concerned that his cough is a habit, but they're also worried about his noisy breathing whenever he gets sick. So we're going to ask again the same sort of format of differential diagnosis as well as evaluation. So Dr. Boo, what would you do at this point?
Well, some of the pulmonary conditions to consider for this patient would include asthma, allergic rhinitis, adenoid hypertrophy, upper airway cough syndrome, and dysphagia. With pulmonary aspiration, and my evaluation would include a detailed history and exam. And then based on this information, some diagnostic testing could include spirometry, fractional exhaled nitric oxide, a complete blood count with the differential to look for eosinophilia, allergy testing, and potentially a chest X-ray to look for any airway inflammation or pulmonary malformations.
Dr. Meister.
So from an otolaryngology lens, I'm thinking about both structural and systemic reasons for cough from the nasal airway down to the trachea. So allergic rhinitis, chronic adenoiditis, laryngeal reflux, laryngeal or tracheal stenosis, tracheomalacia, vascular ring. In older children, sometimes an autoimmune process is a consideration, or habit or functional cough. Our workup, as always, a history, physical exam. Particularly in the history, we want to know about history of intubation, recurrent croup, noisy breathing, any stigmata of atopy. I'll often do an in-office flexible nasolaryngoscopy, and likely a laryngoscopy and bronchoscopy in the operating room, coordinated with our aero colleagues. If the history is especially concerning, or if the workup suggests more concern, cross-sectional imaging of the neck and chest is also a consideration.
Jenna Bernstein, or SLP. Do we have Jenna here?
Jenna, you're on mute.
Apologies, you guys. So as Dr. Meister and Dr. Boo had mentioned, we would want to get a complete case history focusing specifically on those dysphagia symptoms. Is the dysphagia with liquids, with solids, with both? When did it start? We'd also want to get kind of a history of voice and if there are any other concerns that might be impacting. Based on that, we would perform a clinical feeding evaluation as April had reviewed in the prior case, and then we would likely proceed with a fiber optic endoscopic evaluation of swallowing to assess for aspiration as a contributor to the chronic cough and to the dysphagia. Sometimes children with a history of dysphagia, with a history of allergies, will have just this history of uncomfortable feeding experiences, and a speech language pathologist can help provide strategies to support children and families with those difficulties.
And last but not least, GI Dr. Gugic.
Well, thank you very much. And this is something that we see fairly often. I think we need to focus on 2 points here. Number one, the chronic cough, and is it related to a GI cause, such as aspiration, as mentioned before, tracheoesophageal fistula, or reflux. We tend to want to blame everything on reflux, I guess. And then from the dysphagia point of view, we want to look at things that affect the esophagus, primarily either mucosal, such as reflux, eosinophilic esophagitis, either structural, like a tracheoesophageal fistula, and even motility studies. As mentioned before, when they were talking in the previous case about Costel syndrome, we do have patients present with chiari-1 malformations that can have feeding difficulties, dysphagia, and chronic cough. So certainly besides a swallow study, I would want to start my evaluation with some contrast study or an esophagram, and then decide with the group whether an impedance pH study or an endoscopy should be indicating and the timing for these. Thank you.
Thanks, Dr. Gugic and the rest of our Aerodigestive team. So that was an excellent start. So we're going to hear another few key discussion points and talks from our colleagues pertaining to our patient. And then we'll circle back around to our final workup diagnosis and another Q&A.
So good morning, and thank you for allowing me to present. Dr. Seidel has given me all but 8 minutes to go over everything that's important about eosinophilic esophagitis, so I'll try to do my best to get through all the important parts. So just a little bit of background. So this was initially described in the 1970s as a rare cause of illness, but it wasn't until 20 years later in the 90s that it began to be described as an entity. And as a distinct entity, it was described in 1995. Initially, it was unclear if it was EOE was a separate disorder or disease, but part of a spectrum of eosinophilic gastroenteritis. And since the 90s, the number of reported cases has increased worldwide. And you can look here at the distribution of EOE in 1995 and what that change looks like back in 2013. The age of onset, you can see there's 2 peaks. In regarding to us, it's the peak is between 5 and 10 years old. What I want to point you to is this number of incorrect diagnosis. So many people were lingering around without knowing exactly what they had for many, many years. And so you really have to think about this to make the diagnosis. It's important to know what the natural history is. And here's a prospective study of 30 adults followed by for more than 7 years. And you see that 29 of 30 had persistent dysphagia. Almost half had underwent at least 1 dilation. There was deep biopsy tissue available in 7, and 6 of these exhibited evidence of fibrosis in the lamina propria. And although variable, all had persistent and severe esophageal eosinophilia. So it's important that we change this natural history by being aggressive while we're treating our kids. And this is, again, from this study and looking at the natural history of adults. You can see that after 5 or 8 years, the amount of patients that had normal esophagus, quote unquote, was almost non-existent. So hopefully we can change this natural history. Now, the diagnosis of this disorder is always made by the number of eosinophils per high power field seen in the esophagus. So one may ask or has to ask, what is normal? And really in esophagus, we should not have any EOs present. We can have some in the gastric antrum, duodenum, and colon, as you can see here. And the fact that you have eosinophils in the esophagus does not mean you have eosinophilic esophagitis. As you can see on the list here on the left, there's several disorders, including celiac, IBD, upper eosinophilic syndrome, achalasia, and others that can present with eosinophilia without making the diagnosis of eosinophilic esophagitis. So this all led to a consensus, led in part by pediatric gastroenterologists in 2007. And it was a clinical pathologic diagnosis with symptoms, as you can see above, with 15 at least per high power field eosinophils at 40x magnification. And it's important that the remainder of the GI tract was normal. And there was absence of any other disorders that we saw on the list that can produce eosinophils in the esophagus. So what happened between 2007 and 2011? The amount of publications doubled, but as you can see, a lot of people, or very few people, actually used any of the guidelines and recommendation. And furthermore, even though the publications doubled, many of the investigators that were publishing were not using the clinical pathologic diagnosis. So any patient with eosinophilia or food impaction or endoscopic findings were diagnosed as eosinophilic esophagitis, which obviously is not what you want. This led to an updated consensus in 2011 with 33 physicians over 6 months, in which a conceptual diagnosis or definition was elaborated, saying that eosinophilic esophagitis was a chronic immune and antigen-mediated disorder that caused esophageal disease, esophageal dysfunction, and was characterized histologically by eosinophilic predominant inflammation, and that pediatric and adult disease were likely the same. And so if you look at the diagnostic guidelines, again, it is a clinical pathologic diagnosis. The number of eosinophils remain the same at 15 plus per high power field. It has to be isolated to the esophagus, which means that you need biopsies from the stomach and the intestine when you're evaluating these patients. You want to be sure that you're not dealing with other causes of eosinophilia in the esophagus. And now PPI responsive eosinophilic esophagitis or esophageal eosinophilia that responds to PPI is a separate real entity. And just a note that rarely you can have less than 15 eos per high power field, but some other features present and still have the diagnosis of eosinophilic esophagitis. Because of time, I'm not going to go extensively through pathophysiology, but essentially we know, or we think that there's intraduodenal allergen exposure, predominantly from food antigens that come predominantly from the proteins in food as opposed to the carbohydrates or fat. There's then mucosal production of eosinophilic chemoattractants, influx of eosinophils into the esophagus with release of mediators and subsequent esophageal dysfunction. You can see it's way more complicated than that, but once you have all these mediators released, there's proliferation of muscle that causes rings and food impactions. And you can see here on the bottom right, an EUS picture with the arrow pointing to hyperplastic muscle layer. There's also activations of myofibroblasts with increased fibrosis and strictures and proliferation of basal layer with also other tissue changes that cause the symptoms and the appearance that we see under the esophagus. Genetics also plays a role, and this is evident by increased incidence in siblings and first-degree relatives. There has been a gene identified at chromosome 5q22 and the so-called TSLP gene, which has been implicated. You can see here when looking at gene expression versus normal patients, EOE patients have a lot of genes that are downregulated and others that are upregulated. Furthermore, when you look at microRNA expression in allergic and control patients, you can see all the mRNAs are upregulated. And furthermore, if you look at tissue, there's a strong expression of eotaxin 3 in esophageal biopsies compared to normal patients and other patients with esophageal problems. As said before, the clinical presentation varies by age, and younger patients would have feeding disorders, vomiting, and even failure to thrive, while older patients would have abdominal pain, dysphagia, and food impaction. And these are some of the findings that we see on endoscopy. This is the same patient before and after with esophageal furrowing, patients with white plaques, which actually are eosinophilic abscesses before and after treatment. You can also see esophageal fragility and esophageal rings, which really look like a trachea instead of an esophagus, but these are from actual patients. We actually have a classification and grading system for the esophageal findings in which we look at edema, rings, exudates, furrow strictures We describe whether there's mucosal fragility or not, and whether the esophageal caliber is narrowed and by how much. When you look at the prevalence of endoscopic findings, I want to point you to children, and more likely we have linear furrows, white plaques, and decreased vasculature as the predominant things seen as far as endoscopic findings in children. Obviously, we need histology, and it's important to note that it is a patchy disorder. We need multiple biopsies. And again, it's very important because we use this to determine the number of eosinophils per high power field. The number of biopsies are important, and we usually take biopsies from lower, mid, and upper esophagus, and we take 3 to 4 from each site. And the number of biopsies, as you can see, are important because the a percentage of positive diagnosis changes with the number of biopsies you take, and this is true for pediatric and adults. How do we treat this? Well, initially, the initial studies looked at systemic steroids, and this are 20 patients, and they initially were using 1.5 milligrams per kilo per day for 4 weeks and weaned over 6 weeks. And you can see that it improved not only the clinical symptoms, but the number of eosinophils per higher power field. Obviously, with systemic steroids, there are side effects, and it was unclear what the incidence of relapse and the duration of relapse was. And here's from the same studies, but now using 1 milligram per kilo BID with a maximum of 30. And you can see that pre and post treatment, it seems to work, which led to using topical steroids. And this is the initial studies in 1998 on 4 kids using fluticasone with improved symptoms and histology and minimal side effects, although you can see candidiasis in patients. And these are different studies of pre and post treatment using swallowed fluticasone, which is something that we use very often. I will point you to the fact that these are all different kind of studies. Some are retrospective, some are controlled trials, and you can see the doses of fluticasone are also different. This is comparing the type of steroids, either fluticasone versus prednisone, and you can see that they are similar, with the exception of side effects are more prevalent in prednisone, but the recurrence is more or less the same, which led to using liquid budesonide. And this is a study of 20 children, and we mix it with Splenda paste. And you can see that in this study, we had, out of 20 patients, 16 responders, 3 partial responders, 1 non-responders, but there was really no significant adverse side effects, but they did see candidiasis in 1 patient. The important thing of this slide is to show that budesonide not only improves eosinophilia, but also fibrosis. So really intervening early can actually modify the natural history of this disease. Diet is very important. We already talked about the role of diet in producing this disease. The initial studies used elemental diet, and it improved the symptoms and histology. You can see here from that study that elemental diets, improved the histology on these patients as well. There's different type of diets. Obviously, it's easier to put a smaller child, an infant, in a purely amino acid-based formula. It's a lot harder to do this in a toddler and older patient. So we can either do total elimination diet or selective diet, which can be directed if you know the antigen or antigens that are causing the problem, or you can do a 4, 5, or 6 elimination diet. And here's a comparison. Obviously, doing a complete elimination diet will give you significant improvement in the majority of the patients, but even doing partial will give you in the mid to high 70s response rate versus placebo. Other treatments, there's been mast cell stabilizers, leukotriene receptors antagonists, anti-tumor necrosis alpha antibodies. Again, because of time, I'm not going to go into this. I will just mention IL-5, which is a cytokine that regulates eosinophilic function, and overproduction in transgenic mice leads to eosinophilic esophagitis. And here's showing what anti-IL-5 can do in the esophagus. It really decreases the number of eosinophils after treatment. So this is, again, in the horizon. So as far as conclusions, we know that EOE is a clinical pathologic disorder diagnosed by clinicians. It can occur at any age. It seems that adult and pediatric disease is the same. the incidence probabilities continue to increase. You have to think about it to make the diagnosis, and it's important to make the differentiation between other causes of eosinophilia in the esophagus and whether it's going to be PPI responsive or not. I will say stay tuned, because I expect that guidelines and therapy will be greatly expanded and ever changing. Thank you very much, and I hope you continue enjoying the CME, and hopefully we can answer some questions. Thank you.
Hi, I'm Kara Meister. I'm one of the pediatric otolaryngologists. I am going to spend a few minutes speaking about the airway and esophageal pathology. So there are many esophageal conditions with airway manifestations. We are going to touch on a few: eosinophilic esophagitis, GERD or LPR, ingestions. We're not going to cover vascular rings, tracheoesophageal fistulas, or other structural considerations, but those are definitely still in the differential. So getting right to EOE, we've heard a lot about EOE already. As an otolaryngologist, I am thinking about the patient with comorbid atopic disorders, and those with airway symptoms may present 3 years earlier than patients with GI manifestations. The larynx is really the interface between the nasopharynx and the esophagus, and the real estate is small. So in younger children with smaller anatomy, that space is shared. And so inflammation and aeroallergens that are affecting one organ system are very proximally close to the other. We know that in children with eosinophilic esophagitis, up to 1/3 of them can have eosinophils in their laryngeal mucosa. And we also know that as otolaryngologists, we see a certain subset of these patients as their primary diagnostician. And so they may present first to us before we then involve our GI colleagues. Of those that present to an otolaryngology clinic, up to 15% may have no GI complaints. We will sometimes see recurrent otitis media, sinus disease, and adenotonsillar hypertrophy in these kids also. As far as symptoms, I'm thinking about kids with stridor, dysphonia, chronic cough. They can have many concurrent diagnoses that are part of their inflammatory spectrum, especially recurrent croup. Children with recurrent croup, this is very high on our differential. This is a young 2-year-old boy with croup-like episodes, chronic cough, sleep disordered breathing, picky eater. And on nasal endoscopy here, we see markedly inflamed adenoids, erythema of the sinonasal mucosa, thick mucoid secretions. On his airway evaluation, there's lymphoid, polypoid mucosa on the posterior pharyngeal wall, laryngeal edema. This is his trachea with what we call cobblestoning of the mucosa, as opposed to a healthy trachea, which looks like this. So you can see a very distinct difference between those two photographs. And this patient was diagnosed with EOE. We see a lot of reflux in our clinic and a lot of suspected reflux in our clinic. The relationship between reflux and airway symptoms is complex, it's likely bidirectional, and it's really poorly defined. We actually can't diagnose this on a flex scope in the office. Here in this middle panel, we see airway inflammation, petechiae, friability. And here on the right, this is a sleep state, sleep endoscopy, where we actually see refluxate coming up from the esophagus and spilling over into the larynx. And so there's, it's not surprising that she was so friable for Dr. Morales' BAL. From an otolaryngology standpoint, many of these children have reflux that's more alkaline or weakly acidic. And so an impedance probe is not always diagnostic in our patients with airway symptoms. There has been some early data looking at the value of pepsin to diagnose non-acidic reflux in patients with laryngomalacia. These symptoms can be somewhat vague, but dysphonia, stridor, sleep apnea, chronic congestion, with or without classic GI symptoms may all be hallmarks of reflux. The dysphonia can be as severe as a structural lesion, such as vocal cord paralysis or scarring. Here is a young girl who presented with a polyp in her postcricoid space. I'll turn the volume up so you can hear her cry. It's quite hoarse and raspy. We were treating her for subglottic stenosis and dysphonia. She also had significant dysphagia and had an element of likely of dysmotility, but her esophagus showed severe erosive esophagitis and severe reflux in her workup. And this is a middle panel is her subglottis. This is us dilating, and we could do this 1,000 times, but unless we fix that esophageal inflammation, the problem is going to continue to recur. So we also think that it's fascinating treating these children's esophagus and decreasing their aerodigestive inflammation may restore sensation to the larynx and improve swallow function. And very briefly, a public service announcement. So any child with acute onset dysphagia, there must be a suspicion of acoustic ingestion or button battery ingestion. And here are a few photographs from our center over the past year or so. This is a toddler that ingested a household cleaner. This is actually his airway, although it's really difficult to make up anything. And externally, he looked totally normal. This is a double ring sign of a button battery in that patient's near transmural burns of the esophagus. And I will add that the new air tags that have come on the market are powered by button battery. And so please keep this high in your differential.
All right, so we just heard an excellent differential diagnosis and two very pertinent lectures from our panelists. Now I'm going to go back to this case. So let me remind you, this is a 6-year-old boy with a history of eczema and allergies who presents with 3 years of chronic cough, recurrent croup, and intermittent dysphagia. The parents are worried because they think his cough is a habit, but when he gets sick or has a virus, his breathing becomes very labored and very noisy. So what do we do for this patient? Well, we perform an intake where the nurse practitioner calls the patient and gathers all of their information in previous studies. We review the intake and the history as a team, and then we order some items before clinic. And the pre-clinic workup for this patient included some basic labs, all of which were negative with the exception of some peripheral eosinophilia, which elevated peripheral eosinophil count. We reviewed the patient's allergy panel, and this demonstrated multiple aeroallergens as well as food allergens. We obtained a neck and chest radiograph, both of which were normal, and the patient was in the well state during the time of the study. We ordered a video fluoroscopic swallow study, which you can see here, which was largely normal, except potentially some residue during the swallow. And we also ordered an esophagram. The esophagram was normal with the exception of some increased transit time and potentially some thinning of the esophagus throughout the esophagus length. During the clinic visit, we gathered some additional information. The patient had never been intubated, and we care about that when we're considering the diagnosis of croup. The croup episodes were described as very acute onset. Many times they would happen in the middle of the night. The patient would be able to go to the window or have a steam shower, and the symptoms would go away. The throat clearing or habit cough occurred between croup symptoms. It was totally different. And when we asked the family if this occurred during sleep, they mentioned that it frequently did, which leads us away from the diagnosis of a habit type of cough. The patient did have some aversion to certain food types that caused the symptoms to become worse. And when we asked about the dysphagia symptoms were severe. One other thing that I will add is that when the patient had most of the croup symptoms, they were not associated with a virus for the most part. But if the patient did get a virus, his airway obstructive symptoms were severe, very noisy, very labored, and they lasted much longer than the brief nocturnal episodes. We did an endoscopic evaluation of swallowing in the clinic. And what I want to point out here is this very thick epiglottis that you see in the middle of the screen. That is not something that we see all the time, but it's pertinent in this case. I don't want to go through another swallow evaluation with you because I know you've seen some of these already, but I do want to point out that we recognize the laryngeal inflammation during this study that we didn't actually see or appreciate on the video fluoroscopic swallow study that was done with barium. We took the patient to the operating room and we did a combined triple endoscopy where our pulmonary colleagues did a bronchoscopy and lavage. I did a microlaryngoscopy and rigid bronchoscopy. We did EGDs with biopsy, and we ultimately, after doing the EGD, did not place an impedance probe. But what I'll tell you is that we did this as a team under one anesthetic in a very coordinated fashion. The pulmonary evaluation demonstrated a thick epiglottis. This is the epiglottis on the upper left-hand corner here. And you can barely see where the separation between the tongue and the epiglottis. The trachea was inflamed, as well as the mainstem bronchi were inflamed, and some of the segmental airways down below. And as you'll see as this video plays out, there is also some mucus down in the small airways, which was ultimately cleared. In the picture in the lower left-hand corner of these 4 photos here, you can see there's actually a narrowing here where we have almost what looks like a scar band in the back of the airway. When I sized the airway was smaller than it should have been for age. And then further down the airway, the trachea and the mainstem bronchi were again very inflamed. We performed an esophagogastroduodenoscopy with biopsies, and this demonstrated just on visual inspection some of these linear furrows here and these small white dots we call microabscesses. Biopsies were again performed, but just the visual appearance of this was consistent with something that we call eosinophilic esophagitis. On lavage, we did not grow any organisms on culture, but we did have an elevated neutrophil count suggestive of inflammation. But maybe more importantly, on the esophagogastroduodenoscopy, the esophageal biopsies demonstrated significant increases in the eosinophil count for all 3 levels of the esophagus where biopsies were taken. So what does this mean? Well, this means that the diagnosis is eosinophilic esophagitis, and it is likely the cause of much of the cough, the dysphagia symptoms, and the croup-like symptoms that are occurring during illnesses, as well as the nocturnal spasmodic episodes. What's the outcome? Well, in the picture on the left, you can see the epiglottis is much thinner, the pharyngeal edema is significantly improved, and in the video on the right, the segmental airways are markedly less inflamed on visual inspection. On direct laryngoscopy, we demonstrate a much thinner epiglottis, reduced pharyngeal inflammation. That subglottic inflammation with narrowing is almost completely resolved, and the bronchi and segmental airways are also much less inflamed visibly. So what does this mean for the patient? Well, yes, we saw them in the Aerodigestive clinic as a team. We came to the conclusion that the patient has eosinophilic esophagitis, and now we can send the patient to the EOE clinic. The patient does come back to both their primary care providers as well as the Aerodigestive clinic for evaluations as needed. All right, so that was case number 2. And for those of you who have joined us, I again just want to thank you all for being here with us today. We're going to open up again to questions. Please put them in the Q&A box. We've had several comments just to us as panelists, as well as to the rest of the group. There's a comment that was made about the severity of button batteries, and I really want to point out to Dr. Meister, it was excellent to squeeze in that PSA because although it may not be directly related to our case here, it is very, very important. Button batteries are something that has to come out, immediately when they're identified. Dr. Balakrishnan did a great job at pointing out the fact that the double ring sign is where you can differentiate a coin from a battery, where you have actually 2 rings. And if you get a lateral view, there's also something called the double bubble sign, where there will be the posterior aspect, or one side of that disc will be a little bit longer than the other. So you'll see a little hump, and that will be suggestive of a button battery, something that should come out right away. I want to get back to the EOE presentation here, you see how well that our patient responded to treatment for EOE, and it makes us think, well, why would we ever let a patient like that sit around at home suffering? I can tell you that there have been patients that have come into my clinic at least 2 times before I said, you know what, I think you may have eosinophilic esophagitis and we need to work this up. Dr. Gugig told you EOE can be missed for years. So Dr. Gugig, a question that I have for you is, what would you tell a pediatrician who sees patients in clinic with some of these relatively nondescript symptoms? What are the top 3 or 4 things that if we see those, we should at least have this in the top of our head and maybe be sending these patients to you?
Yes, I think that as one of my slides alluded to, it depends on the age of the patient. Some of the symptoms are different. The younger kids usually have feeding difficulties, vomiting, it can be confused with reflux. I always tell the pediatricians, if you're treating somebody for reflux, and the pediatricians know because they follow all these kids, I mean, reflux usually is kind of worse between 3 and 4 months and then starts getting better slowly. If you don't see the regular pattern or you don't see improvement as you see with the other kids, and think, well, could this be more than reflux? And do we think about eosinophilic esophagitis? On an older kid, usually when they have dysphagia or food getting stuck, I mean, many times we actually diagnose people when they come into the ER with a food impaction. And later on, we take biopsies at the time we remove the food impaction and we diagnose them. And so, yeah, in some of the studies, the people can be wandering around with this undiagnosed for 5 to 10 years. So sometimes you just need to think about it to diagnose it.
Yeah, it can be quite devastating. And, I want to turn to our pulmonologists now. You guys are frequently working up chronic cough, and a lot of times our patients with eosinophilic esophagitis have a chronic cough. Dr. Morales, if you have a patient with a chronic cough, is there any type of workup you do when you're thinking either eosinophilic esophagitis versus habit versus, do I scope this kid or send them to Roberto?
So that is a good question. Habit cough is supposed to be a diagnosis of exclusion. And I think that's one thing to remember. And I think sometimes you can get a history that really suggests it, but at the same time, if you have a patient who may be more atopic or they have swallowing dysfunction and you just don't really, things you don't know. And sometimes you just don't know until you look. Right. And, I'm blessed to be part of the Aerodigestive team where I can just go, to our coordinators, hey, do you have a spot in Aerodigestive? And let's see if, we can get him into clinic. So I think that I probably, pull the trigger on that gun pretty quickly, especially because I've been more aware of it, right? It's not something that many people are aware of, that you can get recurrent respiratory symptoms with eosinophilic esophagitis. But it's something to think about, especially in somebody who may not be responding to a medication regimen. And the garden variety medication regimens that people will do for somebody who has recurrent respiratory symptoms tends to be, the bronchodilators, inhaled steroids, right? That cures all, except when it doesn't. I think that, something like that is going to make me always question whether a diagnosis, and those are specifically for asthma. We use them in aspiration really for some anti-inflammatory effect, but not necessarily for the best symptomatic control. That would be thickener, not eating. I think you have to have, something in your head. If those medications aren't working, that either that medication isn't right for the medication regimen isn't right for somebody, or that diagnosis is wrong. And many times it's because the diagnosis is wrong. And that's actually, again, that's biased pulmonologists, because we see a biased group of patients, I think. So the ones who have already been through excellent primary care, who've already tried a lot of things, and need sort of that next level, who are not going to do scopes like we are going to do. So
it's an excellent point. And I think what's come out today at a bare minimum is that we're all cross-training. I'm not a pulmonologist, I'm not a gastroenterologist, but the reality is I learned about eosinophilic esophagitis through airway reconstruction training. And we know that airway reconstruction doesn't work if you have eosinophilic esophagitis. That surgery will fail. And I think Dr. Meister was initially going to ask Dr. Fink in our last case, when would you tell Karthik to not repair that laryngeal cleft? Well, if they've got bad reflux or they've got eosinophilic esophagitis, you got to treat that first, or your surgery is not going to work. And that brings me over to, to Dr. Meister. There are several different, types of croup that we see in our clinic. We see patients who have this nocturnal croup, and we have patients who have the croup that's more of the, I got a virus and it lasted 5 or 7 days and I take steroids, but it happens to me, many times a year, or I'm a little bit too old to still be having croup. How do you differentiate those two? And can they happen in the same patient like we're seeing here? I think we know the answer is yes, but what do you have to say about that?
Yeah, so there's a lot to say about croup. So we can think of croup as a diagnosis, and typically think of it as a viral induced barky cough, right? Or we can think of it more as a symptom, which can be caused by many different etiologies. So I tend to think about croup as a sound that comes from a narrow subglottis. And then what is causing that sound is the question to figure out, right? And so any croup, quote unquote croup, before a year of age or after about 5 or 6 years of age is not croup until proven otherwise. So in those kids, we are thinking about glottic webs, other structural abnormalities, subglottic stenosis. In the older kids, we're thinking also about structural abnormalities, but inflammatory processes such as EOE or LPR. I think about croup occurring at night because if we think about the narrowest part of the pediatric airway being that subglottis, or the area just below the vocal cords, it's full of mucus glands. It's what lubricates our airway. Kid goes to bed at night, their natural steroid drops to help them sleep, and boom, things swell, they wake up with croup. They run outside and they scream, their natural cortisol goes up and they feel better, right? It's the same process. And then what is driving that? So is it EOE? We think about that in recurrent croup. If there's no history of viral prodrome, then that may make me more suspicious of that. And if it's increasing in severity or increasing in frequency throughout their childhood, I think they warrant further evaluation.
Excellent. There's a question actually to Dr. Bernstein, and I think it's a great question. Dr. Bernstein, or Jenna, you was one of our speech language pathologists. You're frequently seeing patients who have dysphagia and dysphonia. And as we've heard through our talk here today and with our patient, you can have both of those with eosinophilic esophagitis, but not everybody does. So how do you differentiate the dysphagia you see from esophageal dysphagia seen in EOE versus some oropharyngeal dysphagia, maybe from something else?
Yeah, thanks, Dr. Seidel. I think it's a great question, and one that we can kind of parse through a little bit in getting that clinical history from the family. So for myself, some kind of flags that this might be dysphagia related to EOE versus oropharyngeal dysphagia or aspiration of thin liquids, let's say, is just first the differentiation between where is the dysphagia happening? Is this primarily with liquids? Is it primarily with solids? Is it with both? If we're seeing the dysphagia more so with solids, that might suggest to us that there's a higher chance of EOE, along with our, flexible laryngoscopy and laryngeal assessment. Is there the edema? Are there nodules? These other kind of cues to us that perhaps this might be something esophageal, another process going on, versus discoordination of the swallowing mechanism resulting in dysphagia. Another kind of piece for us that we look at is, when did things start? Oftentimes, if there's oropharyngeal dysphagia going on, we may speak with a caregiver who says, this has been going on since they were born. We've always had coughing and choking with drinking. And I think the important thing to kind of point out is that two things don't happen in isolation. So oftentimes we have a child who, perhaps we meet them later on, but we diagnose, yes, they are aspirating with thin liquids. We also have a diagnosis of eosinophilic esophagitis. Perhaps we also have selective eating. And then we're working together as a team to manage the process that's going on for that child, so we can provide the appropriate intervention medically, and then therapeutically, kind of moving forward after we have, that esophagus managed, the edema managed, how can we continue to support that child and family in progressing in their oral feeding safely and comfortably?
It's an excellent comprehensive answer, but I think what you're trying to tell me here is that you actually have to look at the whole patient and you have to take a great history and you don't just focus on what you do. And, you talk to your colleagues. I think we're really, lucky to have each other in this group. And I want to, again, take this time to slowly wrap up by saying that we have over 25 members of the Aerodigestive Center now. We are all one big happy family, and we are very fortunate to be able to pick each other's brains and quarrel over, what the next best diagnostic mechanism is for our specific patient. There was a question about whether or not we are a CCS specialty care center. All of our providers are CCS paneled, and we see any CCS patient that exists. There is no complex care CCS panel specification now, but we're actually in the process of developing this, and will likely be the first Aerodigestive specific CCS boarded group if all goes as planned.